أيوة السلام عليكم.
وعليكم السلام.
Do you see the screen, this
Yes.
presentation
Yes.
PowerPoint? Okay, so Bismillah, should we start or should we give few minutes for others to join the meeting? So I think we can start now. So I hope that my voice is clear to everyone and that the screen that's being shared now, the antibiotic basic principles. Okay, so it's clear. Bismillah ar-Rahman ar-Rahim. Good evening, everyone. So welcome to the this evening's webinar. Inshallah, today we'll be talking about the antibiotics. We'll take you, inshallah, into practical overview of the antibiotics, its use, and its spectrum of activities. So we'll start. So when we talk about antibiotic, we always talk that this antibiotic cover gram-positive and cover gram-negative antibiotics. So first of all, we need to have that ideas. The gram-positive and gram-negative, it's a way of visualizing and identifying the bacteria in the labs. And this is the way how it's being stained in the microbiology lab through the gram stain. Basically, the purple, it's a gram-positive organism, and the pink, it's gram-negative organism. And the basic, again, bacteria classification, they are classified according to the gram stain into the gram-positive and gram-negative. And gram-positive, they also further classified into cocci and bacilli. Cocci, they are classified into anaerobes and aerobic bacteria. Again, for the bacilli, classified into aerobic and anaerobic bacteria. For the gram-negative, it's the same, classified into cocci, bacilli, aerobic and anaerobic bacteria. You may find this graph or diagram for the non-ID, non-microbit busy slides, but indeed it has its clinical implication, and the best example of that is. So I tried to give scenario for each of the possible organism. Here we'll go through them slowly. This, for example, you have a newborn babies with sepsis with aerobic gram-positive bacilli. Mother, she liked to eat soft cheese during her pregnancy. So by having this initial identification of the bacteria, you know that this is Listeria, which is gram-positive, aerobic gram-positive bacilli. Now, for example, a child who is born at home with home delivery and he presented with difficulty in feeding, initial blood culture, so anaerobic gram-positive bacilli, anaerobic gram-positive bacilli, and here it goes with the here this category, the Clostridia tetani. When you have a child with the nephrotim in-stage renal disease on BD dialysis with abdominal pain, the BD fluid, it grows aerobic gram-negative bacilli that is oxidase positive. By knowing this characteristic, you need to modify your antibiotic to cover the Pseudomonas. 4-month-old with rash, shock, and blood culture grow aerobic gram-negative. And again, this is a medical emergency, and you know, and this baby has meningococcemia. 4 years old with pneumonia and large pneumatococcele. The blood culture grew gram-positive cocci in cluster. Here it goes with Staph aureus. 3 years old with complicated meningitis. The CSF grew gram-positive cocci in chain, which is the Streptococcus. 7 years old in BICU. He is sick. Blood culture grew gram-lactose fermenter aerobic gram-negative bacilli. by knowing that it's lactose fermented bacilli, it's more likely one of the Enterobacteriaceae. Preterm baby in neonatal ICU presented with sepsis, high oxygen requirement, blood culture grow aerobic gram-negative bacilli, non-lactose fermenter, and it's oxidase negative. Here it takes you into these organisms. It can be Serraceous, Stenotrophomonas, or Proteus. 5 years old child with gut perforation post RTA in BICU, the blood culture grew anaerobic gram-negative bacilli, and here it takes you into the bacterioids. 4 years old unvaccinated child with meningitis, CSF grew aerobic gram-negative coccobacilli, and here it takes you into the Haemophilus influenza. The last scenario is that 7 years old child with chronic otitis media, ear swab grew aerobic gram-negative diplococci, and this is Moraxilla catalans. So basically, this is the clinical scenario or implication of that diagram. So it tells biology. So the antibiotics, they are classified into bactericidal and bacteriostatic. And the bactericidal are that antibiotics which kills the bacteria. On the other hand, bacteriostatic are antibiotics that inhibit the growth of the susceptible bacteria rather than killing them, but eventually they will die by the patient immune system. Again, another principle is that in seriously potentially life-threatening infection, you start broad antibiotic and then de-escalate after you got your culture back. And that by diagnosing infection, it's not only by the culture, you need to take the whole patient's like clinical pictures. Any bacteriostatic antibiotic should not be used in treating serious infection like endocarditis and meningitis. So in serious infection where you need rapid like killing of the bacteria, here we target bactericidal rather than bacteriostatic antibiotics. That the killing power of the clindamycin, it's too slowly bactericidal to be used in treating bacteremia. For example, here in meningitis, when we have MRSA, bacteremia or infective endocarditis, we don't use clindamycin because it's bacteriostatic rather than we use vancomycin. The classification of antibiotics into bactericidal and bacteriostatic, the bactericidal are the beta-lactams and other cell wall inhibitors. The bacteriostatic, I collect them into these two species, like clindamycin, camphene-4, trimethoprim, tetracycline, tirazool. Some noise, I think. You can please the background. Someone is there are children who are, or I think it's or Maghrib, it's already ready. They are preparing for the Isha's prayer. So the other example is that linezolid is a bacteriostatic agent against Staph aureus and Enterococcus, but it's bactericidal against Strep pneumoniae. Inappropriate antibiotics has different way of, for example, using wrong antibiotic for apparent infection, which you know the organism, you know which antibiotic to use, or using the wrong dose of the right antibiotics, or using second or third line drug when you have the first line drug for that infection, or using antibiotics in a situation where antibiotics are not indicated, just in case, or continuing the antibiotics when the infection is resolved or not likely, or keeping the coverage broad when the culture reveals a single organism, and reacting to the culture by starting antibiotics without considering the significance of the culture. So this is the way where antibiotic use can be considered inappropriate.
Sorry, Dr. Hilal. Maybe we can alert Dr. Zainab Al Wahab to close her mic because too much noise.
Or you can mute her, I think.
I can mute her from my side.
You can mute everyone.
Yes, better to mute everyone.
Optimizing. I'm just trying to.
I think
from
there is
where
an
I can
option that you can mute everyone.
switch. I'm just trying to figure out where is the option of muting everyone or the other. I think now the noise is stopped. Yeah, I think Dr. Zainab, she already muted
Yes,
her
she
mic.
muted herself, yeah.
Okay, so now we'll go ahead. Okay, so the culture in well-looking patient, it's a bit confusion. Should you start on the antibiotic, and if the patient is on antibiotic, would you continue that antibiotic or not? Now, for that culture, I took the three most important common culture, like blood culture, sputum, and urine. So for the blood culture, when we consider it as pathogen, so when the patient is febrile, when the culture was drawn, or if the fever persists without appropriate antibiotics, that means there is true bacteremia, or the organism is known pathogens, or it grew out of the two sets when you take peripheral and central culture, or it grew within the first 24 to 48 hours. On the other hand, you can consider the blood culture as contaminant if the patient is otherwise febrile, and there is no fever despite lack of appropriate antibiotics. The organism is a skin colonizer, or it grows only in one sit rather than in two sits, or it grows after 48 hours of sending the culture. So this is for the blood culture, how just to give you an idea when to differentiate, is it true pathogen or is it a contaminant? For the sputum culture, you consider it as pathogen if the sputum is grossly purulent, or the patient is febrile, there is infiltrate on the chest X-ray, or there is more of white blood cell, more than 5 to 10, rather than epithelial cells with low epithelial cells. And with that, they call you that the patient has increased oxygen requirement, he has increased respiratory secretion, and there is increased ventilatory setting. On the other hand, you consider it as colonizer if the sputum is scant, clear, or white, or if the patient is otherwise febrile, there is no infiltrate on the chest X-ray, there is more of epithelial cells rather than white blood cells. For the urine culture, you consider the pathogen, the culture as pathogen, a true pathogen, if the urine analysis show more than 10 white blood cells, there is positive leukocyte esterase, positive nitrate, there is few or no epithelial cells, and if the patient is symptomatic. On the other hand, you consider it as contaminant if the urine analysis reveal less than 10 white blood cells, negative leukocyte esterase, negative nitrite, many epithelial cells, and if the patient is asymptomatic. Now, the others think that when we talk about antibiotic, we talk about the minimal inhibitory concentration. And minimal inhibitory concentration, it's the concentration of the antibiotic, or minimum concentration of antibiotic that inhibit the visible growth of the bacteria. But in this illustration, it shows there's different sort of concentration of antibiotics. The lowest one that inhibit the growth of the visible growth, it's the minimal inhibitory concentration. And with that, the antibiotic works by two ways: the concentration dependent and the time dependent. For the time dependent antibiotics, it's basically the property which is associated with the cell wall synthesis inhibitor, like all the beta lactams, the penicillins, cephalosporins, carbapenems, in addition to the vancomycin. And these bactericidal activities, they continue as long as the plasma concentration of that antibiotic is greater than the MICs. The clinical implication of it is that the free concentration of these drugs should be maintained above the MICs, and that's why we need more than OD dose. On the other hand, the concentration dependent antibiotics are that antibiotics which depends on the peak of the antibiotic above the MIC to exhibit the bactericidal effect and it's or the killing effect of the bacteria. And usually it's the property of the protein inhibitors or the like aminoglycosides like fluoroquinolones. And these drugs, they have characteristic of post-antibiotic effect, which mean that they have still persistent effect even after the antibiotic level goes down, even after limited exposure to antibiotics. And this graph, it shows the two types, or indeed the three types of the antibiotics. So this is the concentration-dependent antibiotics. So the bacterial killing, it depends how high the concentration above the minimal inhibitory concentration level. On the other hand, time dependence, it depends for how long the antibiotic concentration is above the MICs. For the concentration dependence, again, it's the aminoglycosides and fluoroquinolones are the typical examples. For the time dependence, it's beta-lactams. For the vancomycin, indeed, it's the area under the curve above the MIC. The other thing is that in antibiotic prescription is the antibiogram. You know, the sensitivity of the community-acquired or hospital-acquired infection vary from one region to another. So you need to know your local antibiogram. So that antibiogram, it guides your choice of antibiotics. And this is example of the antibiogram that is available in each center. It tells you the organism and the sensitivities to the available or to the used antibiotic in that center. We'll now start to move into the antibiotic themselves. They are different mechanism of action of antibiotics. Basically, there is cell wall inhibitors, which include beta-lactam, vancomycin. There is DNase gyrase inhibitors like fluoroquinolones. There is RNA polymerase inhibitor like rifampicin, and there is protein synthesis inhibitor that work either in 30S or 50S ribosomal subunit. This table, it's illustrate, or it sort of tells us the different organism and the antibiotic that can use for each. We'll spend hopefully around 3 minutes on it so that it will consolidate when we come later into the details of each antibiotic. For example, here I will start from the MRSA. The clindamycin, it can be used for MRSA, but we just mentioned that clindamycin, it's bacteriostatic rather than bactericidal. So it should not be used when there is MRSA bacteremia or infective endocarditis or intravascular infection. Rifampicin can be used, but rifampicin usually used as a combination or synergy. Vancomycin is the drug of choice, first drug of choice to use for MRSA bacteremia. With the vancomycin, you have daptomycin as well. You have linezolid and teicoplanin. So these are the usual antibiotics. Again, gentamicin is used as synergy, especially when you have infective endocarditis or when you have hardware infections. Then you have coagulase negative staph, and for coagulase negative staph, it's the vancomycin as the drug of choice. Sometimes also you have other options, the other anti-resistance gram-positive organism agent. We have a child who initially developed Red-Gland syndrome and then anaphylaxis to vancomycin. Then we gave him daptomycin. He developed also anaphylactic reaction to daptomycin. Then we end up with teicoplanin, and it was fine with that patient. For MSSA, you can use the flucloxacin. Flucloxacin later will come, it's the penicillinase resistant penicillins. For MSSA, the penicillin it's not the drug of choice. Neither amoxicillin is not the drug of choice. But when these aminopenicillins, ampicillin, is added with the beta-lactamase inhibitor, the clavulinate, this clavulinate, it inhibits the penicillinase in the Staph aureus and render it susceptible to the augmentin. Clindamycin is also can be used. Rifampicin, we said you use usually with in combination with others. Vancomycin, teicoplanin, linezolid, daptomycin can be used for. It's also effective against MSSA. I want just to emphasize on here ceftriaxone or cefazolin. So cefazolin, it acts against MSSA, cefuroxime, and ceftriaxone. Here in ceftriaxone, you see a lot of scenario in a patient who is admitted for, they call you that a patient admitted with febrile illness or with skin infection, they cover him with ceftriaxone and cloxacillin. Indeed, it's double coverage for MSSA. So rather than taking the ceftriaxone and cloxacillin together, you can select other agent to cover either like the MRSA or resistant streptococcus, for example, ceftriaxone and vancomycin, rather than having double MSSA coverage. Then the enterococcus, you have enterococcus fecalis and faecium. Amoxicillin act for fecalis, but augmentin work for both of them. The vancomycin is also work for these, in addition to other agents that are reserved for the resistance gram positive, like dapto, anticoplanin. Streptococcus, for the streptococcus, penicillin and ampicillin are the drug of choice. Although you can see here the fluoxacillin that is penicillinase resistant penicillin, it also acts against streptococcus, but it does not have that optimal effect against streptococcus for the like penicillin, for the fluoxacillin. Then the other point here, if you see the fluoroquinolones, the moxifloxacin and levofloxacin, moxifloxacin, which is the fourth class of the fluoroquinolones, it maintains that gram-positive coverage compared to others. For the streptococcus, it also covered by the cefuroxime and ceftriaxone as well. For the Neisseria meningitis, penicillin, it acts against Neisseria meningitis. Augmentin, it also acts against it. One thing, ceftriaxone, it also acts, and that the antibiotic that we can use when we have a child suspected with meningococcemia. H influenza, Haemophilus influenza, amoxicillin, it lacks streptococcus, it acts against H influenza. It also it's gram-negative ciprofloxacin act against it. Zitronam is the only gram-negative, and the gram-negative agent is also used. It's also covered by the cefuroxime for the susceptible Haemophilus influenza, and also by the ceftriaxone. Maracilla, it's more or less the same, covered by the augmentin, and that's why the augmentin is the drug of choice, for example, when you have chronic, when you have otitis media, as initial agent. For the E. coli, it does, for the E. coli, if you can see here, the amoxiclav or the augmentin, it does cover it. For the sensitive organism, again, for the Klebsiella, for the Pseudomonas, gentamicin is added, and that's why we added for febrile neutropenia patient. Ciprofloxacin is very good oral option for the anti-pseudomonal coverage. It also, out of the third generation cephalosporin, ceftazidime act against Pseudomonas, and cefepime, it also, the fourth generation, it acts against the Pseudomonas, and it also, buptazo and mirabinum act against Pseudomonas. So that sort of general brief on the clinical indication, or the most important point that we have in the antibiotic coverage. Now we'll start briefly on each of them, and again we cover the basics. So for the penicillin, it's generally the drug of choice for the bacteria once the susceptibility known, like penicillin susceptible Streptococcus pneumonia and ampicillin susceptible Enterococcus. And penicillin, it acts by, it inhibits the cell wall synthesis by prevent the cross-linkage of the peptidoglycans here, as it is illustrated in the graph. The natural penicillins are penicillin G, which is can be used orally, as gastric, and penicillin V, which is used as IV. And this is the coverage. It covers the strep. It's the drug of choice for strep. You can just link the P here in penicillin with the P of Streptococcus. It's the drug of choice for it. It also covers the serum monocytogenes, and it also covers the Enterococcus. In addition, Neisseria meningitis. For the syphilis, it's the drug of choice. And here, for the syphilis, we need just to make sure that when we have a child who is referred as suspect of congenital syphilis, you need to check what the mother, with what the mother she was treated. So she should be treated with penicillin injection every 2 weeks, or and not other than the penicillin, because some of the pregnant women are treated with the ceftriaxone, which is considered not the proper treatment for syphilis. Now, these penicillins, the penicillin antibiotic, they are susceptible to the breakdown by the penicillinase enzyme. And this penicillinase enzyme present in Staph aureus. That's why the penicillin is not the antibiotic that we want to use for Staph aureus. The penicillinase resistant penicillin, you mean the penicillin that have resistance to the penicillinase enzyme in the Staph aureus are cloxacillin, nifacillin, and oxacillin. And they are resistant to the penicillinase because they have bulky residues on their arc chain that prevent the binding by the staph beta-lactamase, and so they can be used as anti-staph. Here they are less effective than natural penicillin against the streptococcus, and this is the point that we mentioned earlier. When we move from the natural penicillin, then we go into the penicillinase-resistant penicillin. Now we'll move into the aminopenicillins. So aminopenicillin is the example of the ampicillin and amoxicillin. And this amino group allow them to enter the porins in the outer membrane of the gram-negative bacteria like E. coli, Shigella, for the susceptible one. That's why they have a bit more of gram-negative coverage for the susceptible organism. But they are vulnerable to the beta-lactamase as natural penicillin. And that's why also they cannot be used for, or they will not cover the Staph aureus infection. So to overcome that limitation of the aminopenicillins, beta-lactamase inhibitor is attached to it or added to it, which is structurally similar to the penicillins. And so they bind to the beta-lactamase and prevent the enzyme from breaking down the penicillin, like flavulanic acid, sulbactam, and tazobactam. And this arm, the flavulanic arm, it also provides additional coverage to additional anaerobic coverage to that of the aminopenicillin and natural penicillins. Then we have extended spectrum penicillin like piperacillin and ticarcillin. Here, the polar chain or the polar side chain allow them to even have better or greater penetration into the porins of the outer membrane of the gram-negative than the aminopenicillins. And for that, they do cover Pseudomonas aeruginosa. They have modest activity against the anaerobes, but they are susceptible to the beta-lactamase of the gram-negative and staphylococci. So this is the piperacillin. But when we attach it to the beta-lactam inhibitors, when we have piperacillin tazobactam or ticarcillin clavulinate, the inhibitors, they neutralize many of the beta-lactamase that present in the bacteria, gram-positive and gram-negative. They do cover most of the aerobic gram-positive, most aerobic gram-negative, and anaerobic except the Clostridium difficile. Finishing from the penicillins, the side effect, 3 to 10% of them, they will have, of patients, they will have allergy to penicillins. And out of these, around 10%, they will have life-threatening infections. They may develop urticaria, pruritus, or angioedema. Other common side effects is the GI upset, drug fever, interstitial nephritis, and hematological abnormalities. Now we'll move into the cephalosporins. For the cephalosporins, they are structurally similar to penicillins, both structurally and pharmacologically. And they are divided into different generations according to the antimicrobial activity from first, second, third, fourth, and fifth generation. Cephalosporins, they lack activity against certain or group of antibiotics. I collected here for you in a limb. So they don't act against Listeria, they don't act against Enterococcus, they don't act against atypical bacteria, and also they don't act against MRSA except the 5th generation cephalosporin, which is the ceftaroline. And this is, they are intrinsically more resistant to the beta-lactam cleavage. And here, it is clear, when we have that table, we saw that cephalosporin, first generation cephalosporin, can be used as anti-staph. So the first generation of the cephalosporin, it's similar to the penicillinase-resistant penicillins with greater gram-negative coverage. We have the cephazolin available as IV or oral, and we have the cephaloxime as oral. They cannot bind to the penicillin binding protein of MRSA, and they lack activity against, as we mentioned, Listeria and Enterococcus. They have poor protection from the most beta-lactamase cleavage of the gram-negative bacteria. That's why they have limited gram-positive bacteria. When we move from the first generation to the second generation cephalosporins, the extended gram-negative, they have extended gram-negative coverage compared to the first generation. The cefuroxime is the best example that we use a lot in our practice. They have activity against E. coli, Klebsiella, and Proteus, again, against susceptible gram-negative. If you can compare the second generation cephalosporin, they have same coverage as aminopenicillin. Out of the second cephalosporin, we have two have anaerobic coverage, which is the cefoxime and cefotetan. Now, the third generation cephalosporins, they are more potent against gram-negative. They have less activity against gram-positive, and also they have long half-life, allowing them for daily dosing. The example of them are cefoxime, which is available orally, and you see a lot of patients from the private who are sent or treated with cefoxime. Then we have cefotaxime and ceftriaxone, which we use to give it BID dose, and it's eliminated by the biliary route. It should not be used in babies below 3 months of age because it's compete with the bilirubin for the protein binding. And we have anti-Pseudomonas third generation cephalosporin, which is the ceftazidime, and it's also eliminated renally. Now for the third generation cephalosporins, there are groups of sporins, and these are space bugs or spice organisms. So space is S for Serratia, Amaricensis, Pseudomonas, Acinetobacter, Citrobacter, and Enterobacter. When we have these organisms in the blood culture, we shouldn't use the third generation cephalosporins. So this group, they harbor chromosomally encoded inducible MC beta-lactamase, which can allow for emergence of resistance during the treatment. So you may start the patient on third generation cephalosporins, but you notice after by 5 days, 1 week that the child start to relapse, and because being on third generation cephalosporins, that switch on the MC gene, which is the beta-lactamase gene, and it becomes resistant to the third generation cephalosporins. Now for the fourth generation cephalosporins, and the example of that is cefepime, there is modification of the R2 chain, which allow for the broader gram-negative coverage, including the Pseudomonas. It maintains high affinity to the penicillin binding protein, gram-positive coverage, but they have very limited anaerobic activity. The fifth generation cephalosporin is the ceftaroline. So ceftaroline is the fifth generation cephalosporin that has anti-MRSA activity and anti-Enterobacteriaceae coverage, but it lacks the ceftaroline lack anti-pseudomonal activity. And also there is no activity against anaerobic gram-negative bacteria. Cephalosporin side effect, allergic reaction, granulocytopenia, treatment for more than 2 weeks, then you need to check for it. Reversible neutropenia, thrombocytopenia, and hemolysis. I remember a patient who is sickle cell disease. He was treated for with ceftriaxone for sensitive salmonella, but after the third day, the patient, he developed severe hemolysis, and it was not known. We just tried to figure out what was the cause. Later, it was linked to the ceftriaxone use. It also can cause hemorrhage, like inhibit the synthesis of the blood coagulation factors, and it also the cross-reactivity with the penicillin allergy. It used to be between 5 to 10, but now most of the resources, it tells you less than 5%. The other things that I want to highlight here is that the third generation, especially the ceftriaxone, when we use it for the complicated meningitis, the prolonged use of ceftriaxone associated with gallstone formation. So when you have a patient who is on prolonged ceftriaxone, you need to like check for, assess the patient clinically for any abdominal pain, and then you may need to do ultrasound abdomen. We have 3 patients who develop this complication. Then we'll move into carbapenems. They are most broadly active antibiotics. Meropenem, like meropenem, imipenem, and ertapenem. And in our center, we use meropenem a lot. I mean, apart from the other, we use meropenem. They are generally reserved for the multi-drug resistance organism, and they are the drug of choice for ESBL producers. They have excellent aerobic activities, and also they do cover anaerobic bacteria as well, between 3 to 5%. So patients who are on carbapenems, they may have developed allergy to penicillin as well in 3 to 5%. Why they are broad spectrum antibiotic? Their structure, the small molecule with large, with the charge characteristics, special boron in the gram-negative outer membrane to gain access to the penicillin binding protein. And their structure rendered them resistant to the cleavage by the most of the beta-lactamases that is available in the gram-positive and gram-negative bacteria. They have as affinity to a broad range of penicillin binding protein from different bacteria. Carbapenems, they have limited activity against Enterococcus faecium and MRSA. This is because they produce altered penicillin binding protein that does not bind to the carbapenems. The side effects of the carbapenems include GI upset, rash, drug fever, seizures with the use of the imipenem. It's one of the side effects associated with the imipenem use, and it's also one of the factors that limit the clinical use of the imipenem. We'll move into the monobactam. So monobactam is the classic example is azithromycin, and it's only for the aerobic gram-negative bacteria. It does not bind to the penicillin binding protein of the gram-positive or anaerobic bacteria. There's no nephrotoxicity as the aminoglycosides, and there's no cross-reaction with other beta-lactamases. And glycopeptides, I think we are good in time. Hopefully, we will not take much of your time. The glycopeptides, the classic example is the vancomycin. It's poorly absorbed orally, and these characteristics allow the use of vancomycin to treat C. diff, Clostridium difficile. It's a large molecule which cannot pass through the porins in the outer membrane of the gram-negative. It's active against all staph and strep, including MSTC or MRSA. It's active against C. diff that we mentioned. The IV vancomycin used for the systemic infection, and BO vancomycin used for the C. diff infection. The Enterococcus, they bind to the D-alanine portion of the peptide, and the Enterococcus resistance due to the it can occur secondary to the modification of this site of the binding. It changed from D-alanine to D-alanine-D-lactate. Interesting enough, this Enterococcus gene mutation for the vancomycin, it's a transferable to other bacteria like staph. And I read about case report of patient has Enterococcus that is resistant, that also affect is ototoxicity and nephrotoxicity. Redman syndrome, which is associated with rapid infusion of the vancomycin due to the release of histamine from the mast cells. Prolong the infusion and pre-medication limit this side effect. They also it present as pruritus and erythematous rash in the face, neck, and torso. Vancomycin is less than 5% of it absorbed from the GI. Inflammatory bowel disease increase its absorption. It has poor penetration into the solid organ. And here, if you remember, I told you that clindamycin, it's had an anti-MRSA coverage, but it's not the drug of choice for the bacteremia, infective endocarditis, or intravascular infection. Vancomycin is opposite to the clindamycin. When you have MRSA, solid organ infection, the vancomycin is not the drug of choice to use it because it has a poor solid organ penetration. If you can see the graph here on the right side, for example, in the lung, the penetration is only between 17 to 25, and in the bone, in the bone, it's between 7 to 13% only. It will distribute it into the body fluid except the blood-brain barrier only with the inflammation. It does cross it. 80 to 90% remove unchanged through the renal excretion, and 17 removed by the hemodialysis. It's bactericidal against most of the Streptococcus and Staphylococcus. However, it's bacteriostatic against the Enterococcus species. The common question is that when we do the vancomycin level, so vancomycin, the monitoring protocols, indeed it differs in neonate. It's different in babies who have severe renal impairment, and it's different in regular babies. So in children who are on QID 6 hourly, you do it after the 3rd dose. It's half an hour before the 4th dose. And at Royal Hospital, we have the vancomycin protocol for both neonate and for the children when to do the monitoring and when to adjust the level. Then we have the daptomycin. Daptomycin is cyclic lipopeptide antibiotic. It has no activity against gram-negative bacteria. It cannot penetrate the outer membrane. It has poor penetration into the lung tissue, and we'll come to know why is that. It causes reversible myopathies with high doses, and it also can cause GI upset and rash. Daptomycin is generally reserved for the severe resistant gram-positive infection like MRSA and VRE, vancomycin resistant Enterococcus. If the vancomycin failed the resistance, and the best example, that child where we take a blend. It's not the drug of choice for pulmonary infection, daptomycin, because it got deactivated by the lung surfactant. Then we'll move into the colistin. It's the polymyxin group. It binds to the negatively charged lipopolysaccharide molecule in the bacterial outer membrane, displaying the calcium and magnesium that normally stabilize the lipid. And also the fatty acid facilitates the insertion of the colistin into the outer membrane. With its bulkiness, it disrupts the lipopolysaccharide molecules, which cause the increase in the permeability of the outer membrane of the cells, and then leads to the lysis of the cell. It active against aerobic gram-negative bacteria, and it lacks activity against other like Serratia and Proteus. It has no activity, colistin has no activity against gram-positive and anaerobic bacteria, and the side effect is nephrotoxicity, neurotoxicity, like dizziness and ataxia. And you know, again, the colistin is the drug that is reserved for the resistant gram-negative organism. Then we'll move into rifamycins. Rifamycins, we have here rifampin, rifabutin, and rifapentine. They inhibit the RNA polymerase, and usually they use in combination for the treatment of the mycobacterial infection. Rifampin that we use, it used in combination also for staph aureus infections. Although yesterday I read a study that look into the use of rifampicin with vancomycin for the prostatic joint infection, and it doesn't have much of significant effect as shown by that study. Rifampin also, we use it in clinical practice a lot when we have Neisseria meningitis and severe H. influenza infection. We use it as prophylaxis. Rifampin is cytochrome B450 system inducer, and rapid resistance develop, and that's why rifampicin, they are not used as a single agent. Rifabutin has less cytochrome B450 system inducer compared with other rifampin. We said it's used for the treatment of TB, especially in HIV. Rifapentine is one of the newest of them. It has long half-life, used to treat TB, and rifapentine in adult used for the treatment of latent TB every week for 12 weeks. When we send the patient for on rifampicin, we need to just advise the patient that you will have orange discoloration of the body fluids. It raises liver enzymes up to 20% as mild raised liver enzyme. Severe raised liver enzyme is very rare. And the other things for rifampicin, it's, as you said, it affects or interact with other medication if the patient is on other medications. And rifabutin can cause uveitis as a side effect. We'll move into the aminoglycosides. They inhibit the protein synthesis, and they are very potent antibiotics. I mean, apart from all the other antibiotics, aminoglycosides are the antibiotics that they maintain their activity, they maintain their potency as it is since they discovered. They are very, very good antibiotic in that regard. For oral absorption and used in combination with other antibiotics for the synergistic effect. We use it, for example, in some gram-positive infective endocarditis. They cause nephrotoxicity and ototoxicity. These aminoglycosides, the positive charged aminoglycosides, they bind to the negatively charged outer membrane, which results in the hole formation in the outer membrane, so that molecule will move and by energy-dependent bacterial mechanism that require oxygen and energy. And the clinical implication of that is that aminoglycosides, they work poorly in anaerobic and acidic environment. So when you have abscess, gram-negative abscess, the aminoglycosides are not the drug of choice. Aminoglycosides, the uptake of aminoglycosides enhanced by the antibiotic that inhibit the cell wall synthesis, and that's why we use it as synergy with other gram-positive coverage, like with cell wall inhibitors. They use streptomycin, used for the second-line treatment of TB. Tobramycin, it has similar activity as gentamicin, but there is no activity against enterococcus. Amikacin, it's used for other aminoglycosides resistance bacteria. The side effects of aminoglycosides are like nephrotoxicity. They penetrate well into the proximal renal tubules. They cause irreversible renal damage, and the renal toxicity usually happens after 4 to 5 days of therapy. They also cause irreversible ototoxicity and vestibular toxicity, and that's why we need to carefully monitor these patients being on aminoglycosides. Moving into quinolones, like we have the ciprofloxacin, levofloxacin, and moxifloxacin. They are bactericidal and they are broad spectrum antibiotics. They do cover gram-positive, gram-negative, some anaerobes and atypical organisms and mycobacteria. They inhibit topoisomerase that regulate usually the DNA supercoiling. And they are excellent oral, they have excellent oral absorption, allowing them to be used as oral option for gram-negative infection. We should avoid antacids because it reduces the absorption. The side effects are dizziness, GI upset, rash, and fever. Here, the ciprofloxacin is very good gram-negative, has very good gram-negative coverage. Then when we move from the cipro to the levo to the mox, levofloxacin is not as active as cipro against gram-negative, but it has enhanced gram-positive coverage. There's increased resistance may limit its use, especially for the E. coli. The other things for cipro, a note of clinical importance is that when you have a patient with salmonella who come from Indian subcontinent, ciprofloxacin should not be used our first line treatment to treat salmonella, because salmonella that from Indian subcontinent has very high resistance rate to the ciprofloxacin. Moving the moxifloxacin, it has poor urine penetration, so it should not be used with the UTI. Quinolones, they cause QT prolongation, and the risk is highest in moxi, the levo, and it's lowest in the ciprofloxacin. That's why it's advisable to do ECG in patient before putting them on quinolones, like ciprofloxacin, levo, or moxifloxacin. Then the flagyl, metronidazole, it's a small molecule, and this small molecule specifically diffuse into the bacteria, and it has a nitro group which reduce inside the cell and form free radicals that lead to the break in the DNA molecules. It is active against anaerobic gram-positive and gram-negative bacteria. It causes discomfort, and also it can cause peripheral neuropathies. Tetracyclines, they inhibit protein synthesis and they interact with 30S ribosomal subunit. They are bacteriostatic. The classic of them are tetracycline and doxycycline. They are very good anti-rickettsial effect and anti-gram and anti-atypical organism. They maintain some gram-positive coverage for some gram-negative coverage, and they are also used for the treatment of the Borrelia burgdorferi and for the Treponema pallidum. Doxycycline has long half-life, and minocycline preferable for the MRSA therapy. The side effect of tetracycline that they cause permanent teeth discoloration. It causes deposition, and they should be avoided in pregnant women and in children less than 8 years to avoid this side effect. Then we have tigacycline. The tigacycline is the glycyl group added to the core structure of the tetracycline. It's insensitive to the 30S ribosomal subunit modification. That's why it's not easy recognized by the efflux pump, and it has very good activity against most of the gram-negative Pseudomonas aeruginosa, Proteus. They may produce efflux pump that recognize the tetracycline. They also cover gram-positive like MRSA, VRE, vancomycin-resistant enterococcus, and penicillin-resistant pneumococcus. Gramphenical, the least we use in pediatric practice, it binds to the 30S ribosomal subunit. It have anti-gram positive, anti-gram negative, and atypical and anaerobic bacteria. We don't use it too much because of the irreversible aplastic anemia associated with its use. It also can cause irreversible dose-dependent bone marrow suppression. Then macrolides, and the example of them, erythrocleromycin and azithromycin. They bind tightly to the 50S ribosomal subunit at locations that block the exit of the newly formed protein. They inhibit the protein synthesis, the macrolides, and they use for atypical pneumonia. We use azithro for the pertussis, for syphilis, Lyme disease. Erythromycin cause GI upset, so it should be taken with the food. They have also activity against atypical bacteria, and most aerobic gram-negative bacilli are resistant to macrolides. The side effects are GI upset. Erythromycin and clerithro, they inhibit the cytochrome B450. Again, with the macrolides, the rest is highest with erythro, which also can cause pyloric stenosis in small babies. Clarithro, and the least is azithromycin. Then we'll talk about the clindamycin that we mentioned earlier in the presentation. It binds to the 50S ribosomal subunit. The binding site gram-negative resistance, it have gram-negative, or the gram-negative have resistance to clindamycin. Due to the outer membrane, they resist the penetration of these drugs into the cell. It's active against gram-positive and anaerobes. Bacteroid fragilis and Clostridium strains are resistant, and indeed, the C. diff colitis is one of the side effects of clindamycin. Then we have linezolid. It's bind to the 50S ribosomal subunit. E. coli has inherent resistance to linezolid due to the efflux pump, and linezolid is generally reserved for the severe resistance gram-positive infection, like MRSA, VRE, if vancomycin fail or there is resistance. It's highly bioavailable, BO equal to the IV, and higher toxicity when the treatment duration goes beyond 2 weeks of treatment. It causes GI upset, thrombocytopenia, and anemia, and it should not be used in patients with, it should not be used with MAO inhibitors or patients who take MAO inhibitors. Nitrofurantoin, it has low level in the blood, so it should not be used for treatment of infection with bacteremia or pyelonephritis. It's mainly concentrated in the urine, only used for the UTI cystitis, but not for the pyelonephritis for upper UTI. It binds to the ribosome and inhibits translation. It's active against negative and gram-positive bacteria. It causes GI upset, pulmonary hypersensitivity reaction, interstitial pneumonitis, hemolytic anemia, and peripheral neuropathy. Sulfonamides, they inhibit the folic acid synthesis by the competitive inhibitors. They are bacteriostatic action. The common use is trimethoprim sulfamethoxazole and dapsone, which used for the treatment of Mycobacterium leprosy. For treatment of leprosy, they are active against some strep pneumonia, some staph, Listeria monocytogenes, and some H. influenza and Enterobacteriaceae. But they have no activity against anaerobes and atypical bacteria. We mentioned that the side effect, they inhibit the folic acid synthesis, but they don't affect the human cells. It's only the bacteria. The side effect can cause hemolytic anemia and aplastic anemia, photosensitivity, and Stevens-Johnson syndrome, also one of the side effects of sulfonamides. They can cause pancreatitis and convulsion as well. So I think we are ending our presentation. This here, again, this diagram, it shows you the broader overview.
It's 20 hours.
The broader sort of illustration of antibiotic. Here the gram-positive antibiotic and the agent that you can use, vancomycin, daptomycin, linezolid. Then you have gram-negative, and in this graph, it tells you the different organisms that can cause different infections. These crazy slides, but just if someone interested, he just can download it or print it. It provides very brief summary of each antibiotics in one page. And with that, I would like to thank you for your attention and for your patience staying with me till this time. Hopefully that we cover the basic of antibiotics. Antibiotics knowledge, it comes with practice. So whenever you have a patient who is on antibiotics, just you can go back and check the organism he is having and the antibiotics that he is on, and what are the other options that we can use. So now I think we can leave some time for questions, like 10 minutes to 15 minutes, for if there is any questions.
Yes, doctor.
Then go ahead, please.
Regarding vancomycin, the level. So no matter what's the frequency, we have to do it before the 4th dose?
No, this is for the Q6 dose. Like for neonate, there is for patient who is like anuric or he has severe renal impairment, the drug dosing, it can be up to and after each dose.
Okay.
And I didn't bring it much here because it has its own protocol, and it depends on you calculate the Schwartz formula. You calculate the clearance. It depends on the which would you prefer. Would you change the frequency or the dosing? But this is the checking the level before the 4th dose for the QID in normal child. And if that is normal, the level is normal, you can check it after 3 to 4 days after that. Then the protocols, both of them for the neonate and the pediatrics, are available in the portal system in our protocol. So you can just approach, you can get it and print it to just have that overview.
Okay, thank you.
Okay.
Dr. Hilal, people are posting their questions in the chat.
So augmentin. So the augmentin, it's usually the diarrhea associated with augmentin. I can say it's for both, because the clavulanic part, it enhances the anaerobic coverage, and as well as it enhances the gram-negative coverage for the amoxicillin itself. Usually, I advise the patient to take it when they are on when they have when they are on augmentin and they have diarrhea, to take yogurt, so that with the bacteria or the probiotics can be helpful in elevating the gingivitis. Here's the question is, why not use teicoplanin since there is no drug monitoring less than? First of all, especially in children, we tend to use the antibiotic that we know well, and we know the pharmacokinetics and pharmacodynamics. The vancomycin, it's not a bad antibiotics. Indeed, it's very good antibiotics. It treats a lot of infections. By monitoring the level as advised and by checking for other side effects, vancomycin, it's very good antibiotics. Teicoplanin, it has its own limitations, and usually it's reserved for the resistance gram-positive organism. We mentioned initially one of the principles is that when you have first line antibiotic, then second line or third line, you don't start with the third line antibiotic before using the second or the first antibiotic. Okay. So I think that's, yeah, I think that's it for the questions here. So if there's no other questions, I would like to thank you again for your patience, staying with me for more than an hour. Hopefully I gave you some overview. I promised the resident that we'll talk about it, and alhamdulillah, we made it. Thanks a lot, everyone. And I think I will close the presentation.